Good day everyone, we are the Group 2 from BSMT33 and join us on our discussion about serological and molecular detection of bacterial infection. Now, this is the members of our group, yours truly, Samantha, Liza, and Sophia Marie. Let me give you a glimpse of the topics we will be going through. First one is human-microbe relationship. Second one is bacterial virulence factors. Next is immune defenses against bacterial infections and mechanism invasion. The fourth will be bacterial invasion mechanisms. Fifth is laboratory detection and diagnosis. Then the group 5 streptococci or Streptococcus pyogenes, and lastly, laboratory diagnosis. For introduction, the human microbiome comprising bacteria, viruses, and prokaryotic organisms plays a vital role in the health by defending against pathogens, aiding digestion, and stimulating the immune system. Infections resulting from harmful organisms causing host injury manifest as clinical symptoms, and the detection methods include culturing bacteria using stains, immunoassay, and molecular techniques. Our presentation will focus on human-microbe relationship, exploring factors interaction with the immune system, and examine common laboratory methods for detecting bacterial infection with a focus on selected pathogens. Next is human-microbe relationships. At birth, a symbiotic relationship starts between the person and the environmental bacteria. This bacteria quickly colonizes surfaces, including the gut, forming a vital connection. The bacteria living on the body surfaces, known as indigenous microbiota, vary in composition and quantity depending on the body area. They outnumber human cells 10 to 1 and collectively may weigh 2 to 6 pounds. Our relationship with indigenous microbiota is characterized by co-evaluation, co-adaptation, and codependency between the bacteria and the host. Microorganisms survive by colonizing the host, acquiring nutrients, and invading the host's immune response, especially in the case of indigenous microbiota. Once established, they replicate and disseminate to preferred sites in the body for survival, eventually transmitting to new susceptible hosts. There are 3 types of symbiotic relationships between humans and bacteria. First is commensalitic, second is mutualistic, and third is parasitic. For commensalitic relationships, entail no apparent benefit or harm to either organisms, indigenous microbiota is often described as commensals like Staphylococcus epidermis on the human skin. Ibig sabihin, dito sa commensalitic relationship, hindi sila nagbe-benefit sa isa't isa, hindi din sila nag-harm sa isa't isa. Talagang magkasama lang sila. Second is mutualistic relationship, benefit both humans and bacteria. For example, the Lactobacillus species in the vaginal canal produce lactic acid, preventing disease-causing bacterial and yeast colonization. And ang human naman, ang binibigay niya sa Lactobacillus species ay temperature, atmosphere, and nutrients para mag-grow sila. Third is parasitic relationships. The parasite profits at the expense of another organisms, which is the host, frequently conflicting harm or detriment to the host. Ibig sabihin, nakaka-harm yung organism na yun doon sa host. When it comes to describing the interaction between the infecting organisms and the host, the terms used are infectivity, pathogenicity, and virulence. Infectivity refers to an organism's ability to establish an infection. It describes a portion of individuals exposed to a pathogen through horizontal transmission who will become infected. Another term for this is contagious, and the example is the measles virus is highly contagious and has a high degree of infectivity. Another term is pathogenicity. The pathogenicity is the inherent ability of an organism to cause disease determined by its genetic makeup. Some organisms, like HIV, are primary pathogens capable of causing harm to most individuals with intact immune system. Pathogenic organisms may not always cause disease. The outcome depends on factors such as host immunological status. Opportunistic pathogens cause disease in individuals with compromised immune systems due to factors like chemotherapy or chronic diseases. Another term is virulence. So virulence is a quantitative trait indicating the extent of damage caused by an organism. For instance, Yersinia pestis, causing bubonic and pneumonic plague, is highly virulent, often leading to severe illness and death without treatment. So ang virulence is yung nakokos ng organism na damage sa atin or sa host. Yun. So, if a bacterial strain cannot cause disease, it is termed avirulent. And not all members of bacterial species can cause disease. For example, some E. coli are avirulent and some can cause diarrheal diseases or yung pagtatae. So, virulence factors contribute to an organism's pathogenicity by aiding in its establishment in the host, tissue invasion or damage, and evasion of the host immune response. Next is bacterial virulence factors. Virulence factors in bacteria are properties that determine their ability to cause disease. These factors can be structural components like endotoxin or intracellular substances like exotoxins. Pathogenic bacteria possesses genetic determinants allowing them to produce these factors with structural components often encoded on the bacterial chromosome and extracellular products on the plasmids, which are the genetic elements. Acquisition of DNA coding for virulence factors can transform non-pathogenic or non-pathogenic strains into pathogenic ones, and highlighting the role of genetic exchange in bacterial virulence. Next is the bacterial cells, categorized as prokaryotic, differ significantly from eukaryotic human cells, which is lacking membrane-bound nuclei and organelles like mitochondria. Instead, bacterial chromosomes reside in the cytoplasm alongside ribosomes, mesosomes, and potentially plasmids. A key distinction is the presence of cell wall in bacteria is essential for shape, rigidity, and protection against osmotic lysis. Gram-positive and gram-negative cell walls exhibit varying structures with lipopolysaccharide in negative bacteria contributing their virulence through potent endotoxin effects. And now, the successful infection establishment of bacteria requires adherence to host tissue and invasion of the immune system. So, that's facilitated by structural features like flagella and pili. The pili, particularly the fimbriae, enable specific attachment to the host cells, with some bacteria developing resistance mechanisms against phagocytosis and immune responses through antigenic variation. Additionally, surface molecules play a role in attachment, binding to receptors on host tissue. Capsules, composed of polysaccharides, contribute significantly to virulence by blocking the phagocytosis and immune recognition. exemplified by Streptococcus pneumoniae, polysaccharides capsule preventing ingestion by immune cells. The strains lacking capsules are typically virulent. Next is the bacterial-produced extracellular substances further enhance an organism's ability to cause harm by either degrading the body's primary or secondary defense mechanisms, causing harm to host tissues and cells, or aiding in the organism's proliferation and dissemination. These substances, known as invasins, when promoting growth and spread, encompass various enzymes such as hyaluronidase, collagenase, and phospholipases. Now, let's talk about endotoxin or the lipid A. They are found in the LPS layer of gram-negative bacteria's cell walls released upon cell death. It also induces complex host responses, which is first produces cytokines like IL-1 and many more, as well as plate-activating factor causing inflammation, fever, and decreased blood pressure. Next, it activates complement and coagulation cascades, leading to vasodilation, increased vascular permeability, coagulation, thrombosis, and DIC. And lastly, it can cause septic shock, organ damage, and death. No vaccine available to this. Now is the exotoxin. They are protein molecules released by living bacteria, predominantly gram-positive. Endotoxin is gram-negative. Exotoxin is gram-positive. They are highly potent with specific activities. First is neurotoxins interfere with neurotransmitter release which cause muscle spasm. So the example is tetanus toxin. Second is cytotoxins disrupt protein synthesis, and the example is diphtheria toxin. Third is enterotoxins cause diarrhea and inflammation. Example is Clostridium difficile. It is highly immunogenic which induce antibody production. Some of them acts as superantigens, leading to excessive T-cell activation, cytokine release, and toxic shock syndrome. Next is immune defenses against bacterial infections and mechanism invasion. And the next topic we'll be talking about is the immune defenses against bacterial infections and mechanisms of invasion. The body's primary defense against potential pathogens involves intact skin and mucosal surfaces acting as structural barriers complemented by the presence of enzymes and antimicrobial peptides on epithelial surfaces. Example is the lysosome, which specifically targets bacterial cell peptidoglycan and ribonucleases with antimicrobial and antiviral properties. Various ADPs and protein contribute to innate defenses secreted by specific tissues or cells. Among these defensin peptides, constitutively or essentially produced by cells throughout the body. Next is the defensin peptides. So, the defensin peptides are categorized into alpha, beta, and theta classes. First is alpha defensins, disrupt microbial membranes and are synthesized by neutrophils, certain macrophages, and Paneth cells in the small intestines. And the second one is beta defensins, produced by neutrophils and epithelial cells in various organisms, enhance epithelial resistance to colonization. And lastly, theta defensins are absent in humans. These peptides collectively contribute to the body's defense mechanism, aiding in the prevention of pathogen invasion and colonization. Next is the antimicrobial proteins. So the antimicrobial proteins such as complement proteins, interleukins, prostaglandins, and leukotrienes play a crucial role in innate immunity, regulating immune responses, inflammation, and promoting chemotaxis. With regards to acute phase reactants like C-reactive proteins or CRP, haptoglobin, and ceruloplasmin, they activate the complement system, enhance phagocytosis, and exert bactericidal activities. Now, the pathogen-associated molecular patterns or PAMPs on bacteria, fungi, and viruses are recognized by pattern recognition receptors or PRR, triggering immune responses such as cytokine release, defensin production, and phagocytosis. With regards to adaptive immunity, it involves antibody production against bacterial antigens and exotoxins, defending against extracellular bacteria primarily through opsonization. Cell-mediated immunity or CMI targets intracellular bacteria through mechanisms like delayed type hypersensitivity involving CD4 T cells activating macrophages to destroy bacteria. Cytotoxic T cells attack infected cells and granulomas contain infection spread.
So let's proceed to the bacterial evasion mechanisms. So bacterial evasion refers to the various strategies employed by bacteria to evade detection or neutralization by the host immune system. So this phenomenon is crucial for the bacterial survival and persistence within the host organism, so often leading to prolonged infections and treatment challenges. So understanding this evasion mechanism is essential for the development of effective therapeutic strategies against bacterial infections. Bacteria have developed several ways to inhibit the immune system or make it more difficult for immune responses to occur. So there are three main mechanisms na ginagamit yung bacteria natin para maiwasan yung immune responses ng host na kanilang ini-invade. And it includes avoiding antibodies, blocking phagocytosis, and inactivating the complement cascade. Bacteria can evade antibodies by altering their bacterial antigens, and ito yung tinatawag nating antigenic variation. So for example, one example of the bacteria is the Staphylococcus aureus. So they can coat themselves with host proteins such as fibrin or immunoglobulin molecules. Sa Treponema pallidum naman, they can coat themselves with fibronectin, or they can hide their surface molecules through antigenic disguise. So ito naman, antigenic disguise ang ginagamit ng Streptococcus pyogenes through their hyaluronic acid capsule. So bacteria can also evade the specific immune response through downregulation of MHC molecules and production ng mga proteases that degrades IgA. For example na lang dito is Neisseria gonorrhoeae, H. influenzae, and Streptococcus sanguinis. Most of the evasion mechanisms target the process of phagocytosis. So phagocytosis is when certain cells in the body swallow up and break down foreign particles to keep the host or our body healthy. So bacteria can mount a defense at several stages in the phagocytic process, including chemotaxis, adhesion, and especially digestion. So there are microorganisms that use several different mechanisms to resist digestion. So yung mga bacteria na to ay Salmonella species, Mycobacterium tuberculosis, and Mycobacterium leprae. So ang ginagawa nila is binablock nila or pinipigilan nila yung fusion ng lysosomal granules, which is our digestive enzyme, with phagosome. Di ba kailangan natin sa phagocytic process ang fusion ng lysosomal granules with phagosome to form phagolysosome na mag-i-aid ng complete digestion ng bacteria that eventually maglilid sa elimination nito. So the last major defense some bacteria use is to block the action of complement. So yung complement natin is mahalaga din sa ating phagocytic process dahil ito ay nag-enhance ng pag-engulf ng ating bacteria out of our body. So organisms mentioned previously that produce a capsule do not bind the complement component C3b, which is important in enhancing phagocytosis. Such organisms cannot easily be phagocytized unless coated by opsonins. So, dito napapasok yung opsonins natin since yung mga bacteria nga can resist these mechanisms. Dito papasok yung opsonin na tumutulong para sa pag-engulf or pag-phagocytize ng ating mga bacteria. So let's proceed to the laboratory detection and diagnosis of bacterial infection. So laboratory diagnosis of bacteria involves culturing of samples and using various tests that we will be tackled later on this topic that identify the type of bacteria causing an infection. So this laboratory detection and diagnosis will guide us in the effective treatment and recovery of the patient. And here, listed are the various methods or tests that we can use to detect and diagnose the bacteria that is causing the infection. So we have the culture or growth of the causative agent through microscopy. We can also detect them by bacterial antigens in clinical sample through molecular detection of bacterial DNA or RNA, and lastly, through serology or detection of antibodies produced in response to the infection. So let's first talk about the bacterial culture. So various broth and solid media may be used to recover the organism. So some media may contain substances that enhances the growth of certain organisms and are referred to as enriched media. So ito yung mga media natin na may enrichment or may mga certain nutrients na kailangan for the bacteria to grow or to thrive. There are also selective media that contain substances or antibiotics that suppress the growth of commensalistic bacteria and support only the growth of other bacteria. For example, may selective media tayo for Escherichia coli. Bacteria other than Escherichia coli will not grow um, ng maigi doon sa media na yon. We also have differential media that contain substrates that allow for the differentiation of bacteria based on their ability to use the substrate. So, one example na lang dito is the McConkey agar. So, we use this McConkey agar for gram-negative bacteria, and it differentiates the lactose and the non-lactose fermenting bacteria. And some organisms such as Bordetella pertussis na ating causative agent for the whooping cough have very specific growth requirements for which specialized media must be used. And there are also a number of bacterial pathogens for which clinically useful culture systems are not available. And for other organisms, may mga bacteria tayo na it takes too long na makulture siya and bago pa siya ma-identify. And need na ng patient natin ng ASAP or STAT na diagnosis or prescription ng antibiotic. Kaya hindi siya masyado clinically useful. So move on naman tayo sa next natin na detection means, which is the microscope visualization. So visualization of the causative agents using microscopic techniques is most often done using differential or fluorescent stains. So ang mga example nito are Gram stains, acid-fast stains, and Giemsa stains. So ang ating Gram stain, we use this for the differentiation of Gram-positive and Gram-negative bacteria. Sa atin namang fast acid-fast stains, Um, we use this for the detection of Mycobacterium tuberculosis, and for the GEM stain, we use this for the detection of the causative agents of malaria. And currently, many DFAs are being replaced by molecular tests since they lack sensitivity, and because yung mga reagents na ginagamit natin are not widely available. And although naman na easy to perform naman talaga tong microscopic visualization, need pa rin natin ng trained microscopies to properly or um, for the proper interpretation of our visualized bacteria or visualized light. And also another limitation for microscopy is that not all organisms naman can be detected through microscopic visualization. Next naman natin ay ang antigen detection. So, testing methodologies include latex agglutination, enzyme-linked immunosorbent assay, and lateral flow immunochromatographic assay. So, ang advantages ng ating latex agglutination and lateral flow immunochromatographic assay ay madali sila i-perform, they need low cost only, and they have a rapid turnaround time. So, pwedeng-pwede sila sa mga need agad ng result. And bacteria and viruses for which antigen detection is widely used includes Streptococcus pyogenes for strep throat, L. pneumophilia for Legionnaire's disease, rotavirus, respiratory syncytial virus, and influenza A and B. So, antigen detection assays are highly specific, so they are preferred, and because of the advances in technology, the sensitivity ay mas tumataas. So, they are highly preferred in the detection of the bacteria. Then we have molecular diagnosis. So the most widely known molecular technology is the PCR or polymerase chain reaction, in which specific genetic sequences are amplified and detected. So the development of real-time PCR, or the what we call quantitative PCR, has allowed for results to be obtained in a few hours as compared with the several days for traditional PCR. So mas pinabilis ang ating um, amplification ng bacteria. And for some infectious agents such as N. gonorrhoeae and C. trachomatis, nucleic acid-based assays are widely available and clearly the choice for detection. Lastly, for our bacterial detection and diagnosis, we have the serological means, in which we use the antibodies, specifically the IgG and the IgM, to indicate the recent or previous exposure of an organism, and also antibody titers may be used to assess reactivation or re-exposure sa mga previous or infectious agents. The primary disadvantage of using serology in diagnosis is that there is a delay between the start of the infection and the production of antibodies. Although IgM antibodies may appear relatively early, from 7 to 10 days after exposure, some infections have a rapid course, and that needs to initiate therapy limits to the detection of IgM antibodies as a diagnostic tool in those instances. Let's move on to our next topic, which is the group A streptococci. Specifically, we will talk about Streptococcus pyogenes. Streptococci are gram-positive cocci that are spherical, ovoid, or lancet-shaped organisms, often arranged in pairs or in chains when observed on a gram stain. So the streptococci are initially identified by their effect on sheep red blood cells when grown in culture. Group A streptococci are generally beta-hemolytic. So, recall lang natin, if completely nalyze or nahemolyze yung blood cells, they are classified to as beta-hemolytic. And if the organisms only partially hemolyze the cells, causing them to appear green, they may be classified as alpha hemolytic, and if the organisms exhibit no effect naman sa cells natin or the RBCs, they may be classified to as being gamma hemolytic. These are known as the Lancefield groups based on the pioneering work of Dr. Rebecca Lancefield, a member of a beta-hemolytic streptococci. Yung sinabi nga natin kanina is the Streptococcus pyogenes, which includes the group A carbohydrate. So group A streptococci, or the what we call gas, are the major cause of bacterial pharyngitis, a throat infection, and childhood impetigo, a skin infection naman. Additional cell wall components, the M and T proteins allow for further classification and differentiation. So yung mga tests na pwede natin gamitin dito are the serotyping and molecular techniques. Sa serotyping, we can identify the M protein antigens by precipitation with type-specific anti-sera, and more than 80 different serotypes have been identified by this method. However, serotyping has limitations, including limited availability of typing sera, yung mga new M protein types, hindi sila nagre-react with the anti-sera, and this can have a difficulty in interpreting the result. Gas is one of the most common and ubiquitous pathogenic bacteria, and it causes a variety of infections. So the M protein is the major virulence factor of gas, and it has a net negative charge at the amino terminal end that helps to inhibit phagocytosis. In addition, the presence of M protein limits the deposition of C3 on the bacterial surface, thereby diminishing the complement activation. So the M protein helps the Streptococcus pyogenes evade the host immune system by preventing the recognition of bacteria by immune cells, such as the neutrophils and macrophage. They can also contribute to the development of inflammation by triggering the release of pro-inflammatory cytokines and chemokines. The additional virulence factors includes various exotoxins that may be produced sa course of infection. So, one example nito ay ang pyrogenic exotoxins A, B, and C that is present for the rashes seen in the scarlet fever. So, ito yung nagkakos ng symptoms, which is the rashes sa ating scarlet fever. And also, it appears to contribute to the pathogenicity. So, these toxins can target specific cells or tissues in the body and disrupt their normal functions, leading to the characteristic symptoms of the infection. So, yun nga. Itong mga exotoxins nito, they can also cause symptoms. For example, sa scarlet fever ay rashes. Proceed naman tayo sa clinical manifestation ng Streptococcus pyogenes. So, Streptococcus pyogenes can be responsible for infections ranging from pharyngitis sa ating throat to life-threatening illnesses such as necrotizing fasciitis and streptococcal toxic shock syndrome. So, makikita nyo sa picture dito, sa slide natin, ay ang tinatawag na strep throat, which is the most clinically significant sa na infection ng Streptococcus pyogenes sa ating upper respiratory tract. And by the way, the two major sites of infections in humans are the upper respiratory tract and the skin. So, sa skin naman, the most common infection dito ay ang streptococcal pyoderma, or what we call the impetigo. So, humans are the primary reservoir of gas, and transmission of gas is person to person. A small percentage of individuals develop scarlet fever, although usually associated with pharyngeal infections. Scarlet fever may occur with streptococcal infections at other sites. Scarlet fever results from infection with a gas that elaborates streptococcal pyrogenic exotoxins, or the erythrogenic toxins. On the other hand, the toxic shock syndrome is a life-threatening multi-system disease that often initiates a skin or soft tissue infection and maybe proceed to shock and renal failure because of the overproduction of the cytokines. And lastly, the necrotizing fasciitis that may occur when a gas infection invades a muscle in the extremities or the trunk. The reason gas receives so much attention is the potential for the development of two serious sequelae: the acute rheumatic fever and the post-streptococcal glomerulonephritis. So, yung sequelae natin is the follow-up, para siyang follow-up infection from the infection na kinokos ng Streptococcus pyogenes, which are the skin infection, the impetigo, and the strep throat sa pharynx or the upper respiratory tract. The acute rheumatic fever develops as a sequelae to pharyngitis only or tonsillitis in 2 to 3% of infected individuals. It doesn't occur as a result of skin infection. So the latency period is typically 1 to 3 weeks after onset of the sore throat. The second main complication following a streptococcal infection is acute glomerulonephritis. So, unlike the first one, which is the um, rheumatic fever, it only follows the upper respiratory tract infection, which is the pharynx or the strep throat. But itong ating second complication, which is the acute glomerulonephritis, it follows the infections of either the skin or the pharynx infection. So the most widely accepted theory for the pathogenesis of the post-streptococcal glomerulonephritis is the result from this disposition of immune complexes containing streptococcal antigens in the glomeruli.
Now let us proceed to the laboratory diagnosis of the group A Streptococcus antigens or the GAS antigens. So the test used in detecting and diagnosing group A Streptococcus antigens is through the use of culture medium. Uh, the Streptococcus antigen infections is made by the culture of the organism from the infected site. The specimen is then plated on the sheet-fed oven and then incubated. If the group A Streptococcus antigens is present, there is a small translucent colonies surrounded by clear zone of beta hemolysis, which means there is a partially hemolysis occurred in the red blood cell. The identification is made through the basis of basidiazine susceptibility tests and pyrrolvinil B nathylamide or PYR test, and also Lancefield typing when necessary. There are also two alternative tests to detect group A Streptococcus antigens, which are rapid assays and lateral flow immunotherapeutic assay. So the rapid assay is used to detect group A Streptococcus antigens directly from throat swabs. Lateral flow immunochromatographic assays, or LFA, is used to detect Cas antigens for bacterial, viral, fungal, and parasitic antigens. It is more easy to perform and more sensitive than traditional laboratory methods. This is a type of flow assays that is used in outpatient clinics, physician offices, and urgent care facilities for the rapid diagnosis of streptococcal pharyngitis. Including in this method is the extraction of strep A antigen from throat swab that reacts with an enzyme-labeled antibody on a test membrane, which will then be captured by another antibody-specific location on the membrane. So a colored line of the test is indicative of a positive result. Since we have learned that the culture rapid screening has been useful in diagnosing acute pharyngitis, the serological diagnosis is used to identify acute rheumatic fever and post-streptococcal glomerulonephritis because the organism is unlikely to be present in the pharynx or on the skin at the time symptoms appear. Group A streptococci elaborate more than 20 onset exotoxins, and it is the antibody response to one or more of these that is used as documentation of non-suppurative diseases. Some of the exotoxin products include the streptolysins O and S, deoxyribonucleases A, B, C, and D, streptokinase, NADase, hyaluronidase, diphosphopiridine, nucleotidase, and pyrogenic agrotoxins. The antibody response to streptococcal products is variable because of these factors. For example, the age of onset, the site of infection, and the timeliness of antibiotic treatment. The most diagnostically important antibodies are anti-streptolysine O or ASO, anti-DNase P, anti-NADase, and anti-hyaluronidase or AHAS. There are other assays used to detect streptococcal antibodies, which are number one, streptozyme test and serological testing. The streptozyme test is used to detect antibodies to multiple extracellular antigens of group A Streptococcus. Meanwhile, the serological testing is based on an elevated or rising titer of streptococcal antibodies. So, for example, a patient with rheumatic fever or glomerulonephritis uh, can be seen with onset of clinical symptoms because it has reached its peak of antibody response. So, if acute and convalescent phase are tested, a fourfold rise in titer is considered significant. There are the list of or the use of at least two tests for antibodies to different exotoxins is recommended, which are the ASO and anti-DNase-P, because the production of detectable ASO does not occur in all patients. Now we have anti-streptolysine O testing, or also known as ASO testing, which is used to detect antibodies to the streptolysine O enzyme. The toxins produced are the streptolysine S, which is an oxygen-stable and non-antigenic, and streptolysine O, which is an oxygen-labile and antigenic. So the presence of antibodies to streptolysine O indicates recent streptococcal infection in patients suspected of having acute rheumatic fever or post-streptococcal glomerulonephritis following a throat infection. The ASO titer determination was the first test developed to measure streptococcal antibodies. In this test, if enough antibodies were present in the patient's serum, the streptolysine O will be neutralized, thus there will be no visible hemolysis. So the titer of having the reciprocal highest dilution with no hemolysis will then be reported, expressed in either Todd units or international units. So the titer for adults having at least 240 Todd units and 320 Todd units in child will be reported as moderately elevated. ASO titers typically increase within 1 to 2 weeks after infection and peaks between 3 to 6 weeks following initial symptoms. Now we have anti-DNase-P testing. From the word itself, anti-DNase-P is used to detect for the presence of anti-DNase-P. This is clinically useful in patients having glomerulonephritis preceded by streptococcal skin infections, unlike ASO, which is preceded by throat infections. This could also be used to detect patients with rheumatic fever who have a negative result in ASO. This test is highly specific for group A streptococcal sequelae. So the methods used or available in these tests are macrotiter, microtiter, enzyme immunoassay, and developmetric methods. So in neutralization methodology, the presence of anti-DNase P antibodies will be neutralized or will neutralize the reagent DNase B, thus prevents depolymerizing DNA. It produces methyl green color and becomes colorless when hydrolyzed. So an overnight incubation for at least 37 degrees requires in some testing to permit antibodies to inactivate the enzyme. Lastly, we have streptozyme testing, which is a slide agglutination screening test. This measures antibodies against the five extracellular streptococcal antigens, which are anti-streptozin O or an ASO, anti-hyaluronidase or AHAs, anti-streptokinase ASKase, anti-nicotinamide adenine dinucleotide (anti-NAD), and anti-DNase B antibodies. So, the streptozide test is positive in 95% of patients with acute post-streptococcal glomerulonephritis because of gas pharyngitis. So in this test, sheep RBCs are coated with streptolysine, streptokinase, hyaluronidase, DNase, and the NADase. Next, the reagent RBC are mixed with a 1:100 dilution of the patient's serum, and a positive result will have a hemagglutination. Uh, the streptozide test should be used in conjunction with the ASO or anti-DNase B when sequelae of group A streptococcal infection are suspected, and especially useful when negative or borderline ASO test results. On 1982, Helicobacter pylori was first isolated from humans. This organism resides in the gastric epithelium and occasionally in the duodenal epithelium. That is why this is a major cause of gastric and duodenal ulcers. Macroscopically, this is a gram-negative microaerophilic spiral bacterium which is observed in 30% of the population in the developed countries and more than 90% in the developing countries. The high incidence of colonization in the developing countries, where living conditions are more crowded and sanitation conditions are suboptimal, suggests that fecal-oral transmission is the most likely route. And since the 1994, the National Institutes of Health has recommended that individuals with gastric or duodenal ulcers will be given antibiotic treatment along with anti-ulcer treatments. But if untreated, this infection will last for the patient's life and may lead to gastric carcinoma. So there are two types of factors that could cause Helicobacter pylori to a patient. Number one is the cytotoxin-associated gene A or TAG-A, and number two is the vacuolating cytotoxin A or VAC-A. The difference of the two is that CAG-A is a major virulence factor. This protein is injected directly to the host cell by H. pylori, and once it is inside, this disrupts varicella processes like signal transduction pathways and structure of the cytoskeleton, leading to uncontrolled cell growth, altered signaling, and increased inflammation. Meanwhile, vacuolated cytotoxin A or VAC-A is a second virulence factor that codes for the toxin precursor. This means that this toxin acts from outside of the cell and then form pores in the cell membranes, which will then disrupt internal structures like the mitochondria and endoplasmic reticulum and potentially modulating the immune system that could lead to cell death. There is a higher risk of developing gastric or peptic ulcers or gastric carcinoma when you have the virulence factors CAG-A or VAC-A. So the Helicobacter pylori bacteria, unlike many other bacteria, is able to survive and multiply in the gastric environment due to the following reasons. So the spiral shape and the flagella helps these organisms to be highly motile, which means that they cannot just be carried away by the digestive fluids and they can just walk across the stomach lining. And they're also able to penetrate the viscous layer in the stomach. So this organism produces large amount of urease, providing a buffering zone around the bacteria and protects it from the effects of the stomach lining or the stomach acid. So in addition, this flagella is coated with flagellar sheath that protects it from the acidic environment of the stomach. The breakdown of ammonia from urea through the production of enzyme urease produced by Helicobacter pylori will result to a neutrophil-induced mucosal damage. The ammonia has shown to induce the release of toxic oxidants from neutrophils. That is why it causes inflammation and damage to the mucosal cells. So the pathology represents the host's response to extracellular products produced by these bacteria. And once established below the mucosal layer, the organism does not invade to the tissue. Antibodies are formed against the signaling molecules like the CAG-A and the BAC-A, and the strains from individuals with stomach ulcers provide or produce higher levels of BAC-A than strains from individuals without stomach ulcers. So the outcomes associated with the H. pylori exposure may vary because in others it could be asymptomatic, that could persist hyperacidity and will result to duodenal ulceration, and the treatment will include triple therapy with bismuth salts, metronidazole, and amoxicillin. The detection of H. pylori infection can be achieved through invasive techniques or non-invasive techniques. An example of invasive technique is the endoscopy and biopsy. This is a rapid diagnosis of H. pylori infection because it is easy to use and the results can be detected in a short period of time. And because it is rapid, it is also the most expensive and invasive method for diagnosing this infection. However, histological examination reveals a great deal of information regarding the lesion. So an example of a test that detects the urease in the tissue biopsy is the Campylobacter-like organism or flow test. So a biopsy or tissue biopsy is taken from the antrum of the stomach, and when revealed, the yellow color will turn hot pink color in a matter of 20 minutes due to an increase in pH, and the yellow color will remain yellow if there is an absence of urease. Now we will move on to the non-invasive detection methods that includes urea breath testing, enzyme or lateral flow immunoassays, and molecular testing. First is the urea breath testing that includes the patient ingesting urea labeled with a radioactive carbon or the carbon-14 or a non-radioactive carbon which is the carbon-13. So the urea is metabolized to ammonia and bicarbonate. And bicarbonate is labeled carbon dioxide, which is then measured by the detection of radioactivity for carbon-14 or mass spectrometry analysis for carbon-13. This technique has excellent sensitivity and specificity, thus it is helpful in determining if the bacteria have been eradicated by antimicrobial therapy. However, due to the potential for the treatment failure, analysis of stool samples before and after antimicrobial therapy for this antigen is done to determine if the bacteria have been eliminated following the treatment. So we have methods like ELISA tests as well as LFA for this stool antigen testing for initial diagnosis of H. pylori infection. However, there is also developed molecular testing to detect the H. pylori DNA. So this PCR test detects the presence of organism in fecal samples, but they cannot distinguish the live and dead H. pylori. Now we have the real-time PCR technology that is developed to determine the patient's bacterial load and has shown a good correlation with the urea breath testing. The primary method used to detect the H. pylori antibody is through the serological testing. This test is used to detect antibodies produced in response to the bacteria, which are the IgG, IgA, and IgM antibodies. IgM antibody is not used because it lacks clinical value, because most of the infections have become chronic before diagnosis. IgA is also not used because it has lower sensitivity and specificity. However, when used with IgG, it could increase the sensitivity of the detection. Thus, IgG is a primary antibody found using the serological testing. The presence of IgG indicates current or past infection because the bacterium does not spontaneously clear. So the levels will remain high for years in untreated individuals, but levels will decrease in treated individuals. However, it will take for about 6 months to a year. So a decrease in antibody titer of more than 25% must occur for treatment to be considered successful. There are different types of techniques used in antibody measurement. Number one is the ELISA or enzyme-linked immunosorbent assay, which is the most reliable and accurate method. This uses the antigens from multiple H. pylori strains for better sensitivity. We could also use rapid assays, but ELISA is preferred for confirmation. The limitation for this test is that antibody testing isn't ideal for confirming treatment success due to slow clearance, and then immunocompromised individuals will have false negative results. Moving on to Mycoplasma pneumoniae, which is from the class Mollicutes. They are known to be the smallest free living form of bacteria because they measure 150 to 250 nanometers. They are considered to be extracellular parasites because they attach and exist to the surface of the host in which they can absorb their nutrients from. These kind of bacteria lack cell wall, specifically peptidoglycan, but have sterols in their cell membrane. That is why they are difficult to culture. This bacteria is the leading cause of infection worldwide. It is known to be Mycoplasma pneumoniae that causes pneumonia. It could easily spread through contact with respiratory droplets, either by coughing or sneezing from an infected person. So, the diseases or the hallmark for this kind of infection is or are fever, cough, headache, and malaise. Originally, they are known to be atypical pneumonia because the infection could not be treated with penicillin because of what I've said. They lack the cell wall or the peptidoglycan layer in which the penicillin is directed to. Now they are known to be the walking pneumonia because patients with this kind of infection could not or do not have to stay at home from work or school but can still participate in their daily activities. A patient infected with Mycoplasma pneumoniae could develop Stevens-Johnson syndrome or Raynaud's syndrome. The Stevens-Johnson syndrome is also known as erythema multiforme major that causes the top layer of the skin to die and shed. This is caused by a severe allergic reaction to medication or infections, thus this is considered to be a medical emergency. Now we have Raynaud's syndrome, which causes a transient vasospasm of the digits. The fingers will turn to white when exposed to cold. This is a circulatory disorder causing the fingers and toes to go numb and change color to red, white, or blue in response to cold or emotional stress.
Next we have is the immunology of the Mycoplasma pneumoniae infection. So, several classes of antibodies are produced in the course of this infection. However, yung body naman natin ay nagpaproduce ng antibodies that can neutralize the microorganism which serves as its humoral response. So, it induces the production of autoantibodies including the agglutinins directed against lungs, brain, cardiolipins, and smooth muscle. So to be specific, yung cold agglutinins observed with pneumoniae infection ay oligoclonal IgM antibodies directed against the altered I antigen found on the surface of human RBCs. It can also agglutinate RBCs at temperature below 37 degrees Celsius. And yung development niya ay thought to result from the cross-reaction of antibodies against the pneumoniae and the I antigen on the surface of the RBCs, or pwede rin namang from the alteration of the RBC antigen by the organism. Laboratory means of detecting Mycoplasma infection may involve culturing of the organism, which is yung gold standard for diagnosis detection of M. pneumoniae. Also yung specific antibodies in serum and detection of specific antigens or nucleotide sequences directly in patient specimens. So in addition to culture, even though yun nga yung considered as the gold standard for diagnosis, it is rarely carried out in laboratories. Why? Because of the fastidious nature of M. pneumoniae. So in terms of collection and transport naman, iba siya sa traditional na methods kasi it uses the transport media trypticase soy broth with 0.5% albumin, SP4 medium, or a viral transport medium. Para sa growth naman, growth on successful culture ay mulberry colonies with a typical fried egg appearance. Kagaya ng nakita natin sa picture na ayun, parang may mga fried egg yung appearance ng colonies ng M. pneumoniae sa culture. Detection of antibodies of Mycoplasma pneumoniae. So specific here is the detection of IgM immunoglobulin, and it's the most useful diagnostic test because its detection likely indicates a recent infection. However, even though yung IgM immunoglobulin yung primary na immunoglobulin in response to infection, necessary pa rin yung IgG testing kasi adults may only elicit an IgG response due to the reinfection with the organism. So, even though yun nga, primary yung IgM, dapat itest pa rin natin yung IgG. That's why, ayun, meron tayong enzyme-linked immunoassays, which is the most widely used methods for antibody detection. It can detect IgM or IgG, and yung specificity niya ay more than 99% and sensitivity niya ay 98%. For the diagnosis of Mycoplasma infections, molecular methods yung gold standard. However, very few laboratories offer this assay. And ayon nga dito, before 2012, there were no FDA-approved assays available. Pero nung, 2012, the Film Array Respiratory Panel by BioFire Diagnostics Incorporated ay naka-receive ng FDA approval. It uses nested multiplex PCR able to detect 20 respiratory viruses and bacteria including B. pertussis, C. pneumoniae, and M. pneumoniae. And dahil sa additional assays being developed as years pass by, itong molecular diagnosis of Mycoplasma infection ay mas naging widespread na halos nare-replace niya na yung serology as the primary means for the diagnosis of M. pneumoniae infections. Additional information about M. pneumoniae is that the laboratory diagnosis of this organism involved testing for cold agglutinin. So, included naman sa slide yung mga specific description ng cold agglutinins. However, this method is no longer recommended because of the development of cold agglutinins, which occurs in some viral infections and collagen vascular diseases. And also, it is not very specific or sensitive na. Yung cold agglutinins may be found in patients with infections whose clinical presentations resemble mononucleosis and cytomegalovirus. Let's focus now on rickettsial infection. So to start off with rickettsial infections, these are infections of the obligate intracellular gram-negative bacteria Rickettsia. Families of Rickettsia cause a variety of infections in man and animals, and also various members originally belonging to Rickettsia have been reclassified due to molecular technological advancements. So vectors of these infections are specifically arthropods. Yun yung ticks, mites, lice, or fleas which transmit the organism through its bite after feeding on an infected animal. So now for additional information, here's the table containing the classification of selected Rickettsia known to cause disease in humans. As mentioned in the previous slide, yun ngang arthropods yung ating vectors for Rickettsia infection. Pero meron tayong exception and it is the typhus fever or also known as the epidemic louse-borne typhus. It is transmitted when an infected human body louse excretes R. prowazekii onto the skin while feeding and the individual becomes infected by rubbing louse fecal matter or crushed lice into the bite wound. Furthermore, human are accidental hosts for Rickettsia and Rickettsia-related organisms and its distribution is worldwide. However, meron din tayong certain members nitong Rickettsia na may specific geographic distribution and ayan, nakalist naman. So, the genus Rickettsia is made up of two distinct groups. So, nahati pala siya sa dalawang groups. The first one is the spotted fever group or SFG and the typhus group or yung TG. Each of these two are responsible for a different set of diseases. The first one for the spotted fever group is the Rocky Mountain spotted fever, which is the main rickettsial disease caused by R. rickettsia or yon, yung SFG nga, and approximately 2,500 cases of this disease are reported each year. On the other hand, under naman ng typhus group ay yung typhus fever, also known as the epidemic typhus. It is most prevalent member of typhus group globally and caused by Rickettsia prowazekii. And it also occurs in conditions of poor hygiene and overcrowding such as in prisons and refugee camps. Focusing now on the main rickettsial disease or yung Rocky Mountain spotted fever. This is under the spotted fever group. Yung epidemiology niya, it is caused by R. rickettsia and it is transmitted to the human host by a bite of a tick. In the US, yung organism na nagtatransmit nito ay yung American dog tick, Rocky Mountain wood tick, and the brown dog tick. And its occurrence is seasonal lang. And nagko-correspond siya sa tick activity being most prevalent between May and September. So, hindi siya palagi. Seasonal lang itong Rocky Mountain spotted fever. The organism is transmitted transstadially. Pag sinabing transstadially, it remains present in the tick as the tick progresses from nymph state to adult state. And also transovarially, from generation to generation through the eggs of the tick. So, yun yung dalawang methods. Transmission occurs when the tick bites the host for a blood meal. When the tick has fed after 6 to 10 hours, your organism ay injected na into the host from the salivary glands. Now, for the pathogenesis, organisms spread via the lymphatic and circulatory system and nagmumultiply yung organisms via binary fission inside the endothelial cells. And then yon tsaka siya mare-release and mai-infect niya yung other adjacent cells. This leads to hundreds of infected cells producing lesions and skin rash associated with the infection. Yung main pathophysiological event caused by this infection is endothelial cell damage kasi dun nga nagmumultiply yung organisms, which leads to increased vascular permeability, resulting in edema, hypovolemia, hypotension, and hypoalbuminemia. For the clinical manifestations nga, na-mention na kanina yung sa rashes, and the symptoms observed within 2 to 14 days after a tick bite. Most patients before fever, makaka-experience sila ng severe headache, vomiting, nausea, abdominal pain, diarrhea, and abdominal tenderness before yung sa rash. And then mag-start yung fever usually within the first 3 to 5 days after the onset of the symptoms. And rash usually appears 3 to 5 days after the onset of the fever. So usually yung rashes, it starts on the hands and soles of the feet. Tsaka lang siya magpaproceed sa trunk. Pero meron ding cases na nagsastart siya sa trunk in some individuals. So ayan yung picture ng rashes ng clinical manifestation ng RMSF. The initial diagnosis is often made clinically after ruling out a large variety of other conditions, including na yung typhoid fever, measles, rubella, enteroviral infections, and respiratory tract infection. However, yung diagnosis ng initial stages nga nitong RMSF ay considered as extremely difficult due to overlapping symptoms or clinical presentations. And ayun, the diagnosis of fulminant RMSF, kapag sinabing fulminant, ito yung sudden or nag-escalate quickly na condition. And sabi dito, it is even more difficult pa kasi dahil sa rapid course. So, the rash develops shortly before death. Therefore, antibodies to R. rickettsii do not have time to develop. And ayun, the organism infects the endothelial cell and does not circulate until the disease has severely progressed. Therefore, culturing of the organism is not always useful. So, hindi daw useful yung culturing ng organisms. due to the common symptoms of patients having rash. Kaya molecular diagnosis using DNA from the skin lesions is of value. So instead of culture, molecular diagnosis using DNA from skin lesions na lang yung ginagamit. While for confirming the diagnosis of RMSF, serology is the usual method, but it is a retrospective diagnosis. To elaborate, antibodies to rickettsia develop 7 to 10 days after the onset of symptoms. Also, a majority of patients do not show antibodies during the first week of illnesses. So yon, yung mga majority ng patients daw hindi pa nagpapakita ng antibodies sa first week ng illness nila. In order to have a successful outcome, therapy needs to be initiated before that time. So, yung gold standard for serological diagnosis of RMSF ay yung indirect immunofluorescence assay or IFA with R-Rickettsial antigen, which is performed on two paired serum samples to demonstrate a significant four-fold rise in antibody titers. Lastly, we have yung Weil-Felix test, which is an agglutination test which can detect antibodies produced in patients with rickettsial infections. Ito ay based sa cross-reactivity ng patient antibodies with polysaccharide antigens present on the OX19 and OX2 strains of Proteus vulgaris and OXK strain of Proteus mirabilis. However, it lacks sensitivity and specificity, making it unreliable.